Welcome. We are delighted to present this series of educational videos, Pituitary 101, featuring Dr. Louis Blevins, a program exclusively produced by Pituitary World News with important information about the systems that drive pituitary function and, importantly, how those systems are affected by pituitary disease. Here's Dr. Blevins.
Hello, my name is Dr. Louis Blevins of Pituitary World News. Welcome back to Pituitary 101. This is episode 5, and I will discuss the hypothalamic-pituitary-gonadal axis in women. Let's turn to this slide. It shows you that the central nervous system plays a big role in control of the hypothalamic function. And just to give you some examples here, if you're under stress, you're going to shut down your reproductive function and lose your menses. If your body weight is too low, the same is going to happen. If you have an illness or some other medical problem, this is a very sensitive system, and it's going to disrupt menstrual cycles, and you'll notice changes in that setting. In the hypothalamus, we produce a hormone called GnRH. Men and women both produce this, and in both sexes, it's regulated by the arcuate nucleus and the pulsatility of that particular nucleus, and basically which pulses about every 90 minutes. And that pulsatile secretion of GnRH is very important in pituitary function. If I gave you a GnRH infusion, I would shut off pituitary function. If I gave it in a pulsatile fashion every night, I would stimulate pituitary function. So I find that to be very fascinating about this physiology. It's just one of many fascinating things going on in the reproductive axis in women. GnRH, which stands for gonadotropin-releasing hormone, leads to the release of the gonadotropins, which are namely FSH and LH. And they both have different functions in the woman who has an active reproductive cycle during her reproductive years. LH is luteinizing hormone, and it stimulates the theca cells in the ovary, which surround the follicles where the eggs are located, and it makes those theca cells produce androgens. So the ovary produces male hormones in response to LH. FSH tells the granulosa cells, which are the ones that directly surround the egg, to make estrogens. And those estrogens then have their actions on the reproductive tract, lead to growth of the endometrium and some other things we'll talk about a little later. These granulosa cells also make inhibins, which inhibit FSH production, and activins, which activate FSH production. The granulosa cells become luteal cells after ovulation and make progestins. The theca cells also make some progestins. Those have effects on the reproductive tract and especially the uterine lining that we'll talk about. The really fascinating thing about estrogens in this system is that in the early parts of the cycle, estrogens have positive feedback. They don't have the negative feedback that we're used to talking about with these axes. Estrogens early on lead to more FSH production. Later on in the cycle, estrogens, as they rise, inhibit FSH production. So this is one of those systems where there's a switch. You go from being stimulatory feedback to negative feedback, positive feedback to negative feedback. And that's at the level of the pituitary and at the level of the hypothalamus, where estrogens stimulate GnRH for the first half of the menstrual cycle and lower GnRH during the second half of the menstrual cycle. Very fascinating system. What happens if you take birth control pills is that it's basically a continuous dose of estrogen that inhibits pituitary function and inhibits hypothalamic function, so you don't produce FSH and you don't ovulate, and that's what leads to the birth control of taking a birth control pill, or any other form of estrogen can do this as well. If you have a situation where you have an estrogen-producing tumor, you'll see the same. You shut off FSH and LH in that setting too. In menopause, women have an ovarian failure. They're out of eggs, they're out of granulosa cells, so they no longer make estrogens. Actually, due to the lack of estrogens, they make more LH and FSH because the negative feedback is lost. So the pituitary is trying to tell the ovary, make more estrogen. We want more estrogen in the system, but there are no cells to produce it. Interestingly, in some women, those high levels of LH do cause the remaining theca cells, which are surviving usually, to make androgens, and sometimes women will develop a little bit of a mustache or hair growth elsewhere as they go through menopause. And that's because of the loss of negative feedback with estrogens. LH rises, LH stimulates androgen production by the theca cells that survive, and that can obviously lead to the clinical symptoms and signs. This is a really nice slide that shows you on the very bottom the endometrial lining and what's happening, where this is it sloughing off in the first few days of the period and decreasing in thickness, and these are changes that are proliferative, and then the secretory phase where the endometrial lining is the thickest around day 22 to 24. At the top it shows you this is a little follicle. This is estrogens leading to the granulosa cells getting bigger, nurturing the egg, preparing an egg for release. Ultimately, one egg is released in the middle of the cycle, and then those granulosa cells turn into luteinized cells that produce progesterone to maintain this uterine lining. If there's no pregnancy that develops, the corpus luteum dies, and then the endometrium sloughs off and you have your next period. So the best test as to whether or not the pituitary-gonadal axis in a woman is working is if she's in menopause, checking the LH and FSH levels, because I told you those will rise in menopause. If she's a woman of reproductive age, is she having regular menses? And we talk about regular. Normally we like to think 28 days is regular, but for some women that's 32, or for others it's 25. As long as a woman's having a period about every month, I consider that her hypothalamic-pituitary-gonadal axis is probably normal. When it comes to having to check hormone levels, you can see here that these levels all vary greatly throughout the menstrual cycle. You can see that FSH levels start to rise in the first part of the cycle, and then with the positive feedback, you can see them increasing, and then they decline with the negative feedback. The LH spike is one of the many things involved in ovulation. There are other factors too, but you can see LH levels actually start to rise, positive feedback, they spike, that's when ovulation occurs, again in response to other factors too, and then LH levels fall due to the negative feedback. The estrogen levels rise in the first part of the cycle, they're highest mid-cycle, and then they start to fall. There's another little blip in the latter part of the cycle. These progesterone levels rise throughout the cycle towards the end of the cycle because the corpus luteum is making the progesterone. So generally speaking, I can tell patients go to the lab on the second or third day of your period if I want to see everything at their baseline. Go about 14 days after your last period if I want to see everything at the peak. Go at about 21 to 24 days if I want to see if they ovulated, because in that setting I can check the progesterone level and know whether they ovulate. And if they ovulate, that's evidence that at least for that month the hormone system is working well. I think this is all very fascinating. My real introduction to endocrinology was as a third-year medical student on my obstetrics and gynecology rotation, where I spent 2 weeks with a reproductive endocrinologist and learned all of these things. And I think it's in part one of the reasons I became an endocrinologist. I've always been fascinated with the reproductive cycle in women and the different tissue effects of the hormones across the body. And of course, estrogen does a lot of different things in the body once it enters the circulation. It's also bound to sex hormone binding globulin, and those levels do play a role in a storage form of estrogen, probably, if you will. And estrogens can influence sex hormone binding globulin levels too. So as you can see, this complex system is quite fascinating, and simply checking levels of LH, FSH, estrogen, progesterone have to definitely be taken in the context of what's going on with the patient. Is it a menopausal woman where you expect the LH and the FSH to be high and the estrogen and progesterone to be low? Is it a woman with irregular menses, and you can do several samples and try to piece out whether she's ovulating? Or is this a person with pituitary disease, and you have to look at the age and the anticipated hormone levels and know exactly where you might expect those to be. For example, if I see a woman who's 72 years old and she's 20 years into menopause and she has a pituitary tumor, and I see LH and FSH levels that are low, I know that this person has some compromise of pituitary function. If I see a person who's taking birth control pills and has low LH and FSH, I can't tell whether or not she has pituitary dysfunction or whether that's related to the birth control pills themselves. We have patients that have LH and FSH producing pituitary tumors, and it's rare, but some of their gonadotroph adenomas are functional. Those are the ones that are difficult to determine. Is this a postmenopausal rise in LH or FSH, or is this due to the tumor? The clue is often that the tumor would be large and destructive. They would have other hormone deficiencies, but to have LH and FSH preserved would be the clue that that might be a tumor secreting LH or FSH. In summary, it's a very complex system. It requires combining history and physical and laboratory data and radiologic data with the studies that we're assessing to make a decision about whether or not this particular gonadal axis is working normally. Certainly there are a lot more considerations when it comes to deciding on replacement therapy based on age, other health factors, goals and desires, etc. Thanks for tuning in, and stay tuned for more episodes of Pituitary 101.
This is Jorge Fascinetti, co-founder and chairman. Pituitary World News is dedicated to produce content that informs and educates. We are a non-profit organization and as such rely on contributions to fund all these initiatives. We have exciting plans for 2025. If you'd like to learn more about our plans and help, please visit pituitaryworldnews.org and click on the donate button. Every contribution helps, no matter the size. You can also help by sharing all the information available on the Pituitary World News website at pituitaryworldnews.org. We welcome your comments and suggestions. Thank you, and thank you very much for watching.